In clinical practice, an expected therapeutic effect can quickly turn into a medical emergency. To practice safely, a nurse must recognize when a patient shifts from recovery to crisis. These medications target the endocrine system to manipulate metabolic hormones. Because these hormones are so powerful, any deviation from the target level destabilizes vital signs, heart rate, and the immune response. We will organize our management strategy by target organ. For the thyroid, we focus on levothyroxine, PTU, methimazole, beta blockers, and radioactive iodine. For the adrenal glands, we look at hydrocortisone and fludrocortisone. Safe administration requires mapping each of these drugs to a specific red flag, a side effect that demands an immediate, high-priority nursing intervention. Thionamides like methimazole and PTU are designed to halt thyroid hormone production. However, as noted in the nursing actions, they carry severe risks for liver toxicity and a dangerous drop in white blood cell count, known as agranulocytosis. This risk dictates your education and assessment priorities. If a patient on these medications reports a fever or a sore throat, you must hold the dose and immediately anticipate a white blood cell count to rule out an immune collapse. While waiting for hormone production to slow down, we use beta blockers like propranolol. These do not lower the actual thyroid hormone levels. They're used strictly to protect the heart from the stress of tachycardia until the primary treatment takes effect. Radioactive iodine, or RAI, takes a more aggressive approach by physically destroying overactive thyroid tissue. This process makes the patient a temporary radiation risk to those around them. Environmental protocols for RAI are strict. Patients are instructed to avoid pregnant individuals, use separate restroom facilities, and flush 3 times after every use to prevent radiation exposure to others. For hypothyroidism, levothyroxine is the standard replacement for missing T4. Because fiber, calcium, and iron can interfere with its absorption, the patient must take this medication on an empty stomach to ensure the dose is effective. As metabolic rates rise during treatment, myocardial oxygen demand increases sharply. In a patient with existing heart disease, this sudden metabolic surge can lead to coronary ischemia, manifesting as chest pain or palpitations. Managing thyroid medications is a continuous process of observation. You are constantly balancing the need for metabolic control against the risk of immune failure or cardiac overexertion. Patients with Addison's disease require lifelong hormonal replacement because their bodies cannot produce adequate cortisol or aldosterone. Hydrocortisone and fludrocortisone are used to restore this balance. Abruptly stopping adrenal steroids leads to a rapid drop in hormone levels. This triggers a lethal Addisonian crisis, characterized by acute circulatory shock and vascular collapse. Fludrocortisone specifically mimics the hormone aldosterone, which causes the body to retain sodium and water. This necessitates close monitoring of daily weights and blood pressure to catch the early signs of fluid overload or hypertension. Consider these 2 patients. Patient A is taking methimazole and reports a sore throat. Patient B is taking levothyroxine and has a heart rate of 110. Who do you see first? Patient A is the priority. While patient B's tachycardia may require a dose adjustment, the sore throat in patient A indicates potential agranulocytosis, an acute emergency that requires immediate intervention to prevent sepsis. Let's test your judgment. If a patient on fludrocortisone gains 3 pounds in 48 hours, what is your next step? Notify the provider. That rapid weight gain is a clear indicator of fluid retention. Can a patient take their levothyroxine at the same time as their morning calcium supplement? You hold the dose and educate the patient. Calcium interferes with the drug's absorption, making the treatment ineffective. If a patient on hydrocortisone has a severe gastrointestinal bug and cannot keep oral medications down, what is the risk? This is a medical emergency. Without oral absorption, the patient needs IV steroids to prevent an adrenal crisis. This summary matrix highlights the high-stakes complications you must anticipate. Competency in endocrine management is built on identifying these red flags, like agranulocytosis and adrenal crisis, before they progress. Effective clinical judgment requires looking past a medication's standard purpose to identify the exact points where the system